Hi, everyone. I'm going to go ahead and get started. Today is our last seminar of the year. We have made it through academic year 2023, 2024. Entering in finals, well, almost. I think there's still finals going on. But I also just wanted to say something very briefly before we get started. So the Mare Lecture is an annual tradition at CCPR, and it is named in honor of our founding director, Rob Mare, who was also a professor of sociology between about 1997 and 2021. And CCPR set this up because of Rob's long-term commitment to training the next generation of population scientists. And so every year we select a graduating PhD student to deliver a short lecture where they present their research and maybe talk about also, any number of things, including their career plans, and if they wish, some aspects of their graduate career here at CCPR. And the award, so mostly it's about the glory, but the award comes also with a $500 prize. And so this year, CCPR has selected Johnny Huynh to give the lecture. So we're very excited. And I was last minute, but I also asked Adriana Lleras-Muney, who has been Johnny's primary advisor in the past year, just to say a few words about him. And so she generously agreed. So let me turn it over to Adriana.
All right. Well, thank you very much. I'm very happy to be here. I knew Rob when he was around and worked with him at CCPR, so it's my great honor to have my own student be awarded the prize. So I've known Johnny for a long time now. He's one of our prime students, and I'm very happy to report he's going to be going to Dartmouth School of Public Health in the fall. So it's a fantastic job. And we are, in fact, working together on multiple projects. And so I'm very proud that he's here, and I'm very excited about this project on which we work together. And I've also have a lot of similar research to it, so we share a lot of common interest. And I'm delighted to see this project today, and I think it's going to be an amazing publication one day. So I hope you enjoy it, and congratulations, John.
Hi, everyone. So I'm Johnny. I'm a PhD candidate in the Department of Economics, and I'm an incoming assistant professor of health policy at Dartmouth this fall. I also want to acknowledge kind of the Health Policy Research Scholars Program with Robert Wood Johnson Foundation, which has really helped me kind of refine and think about health equity. Kind of my research uses economic models and causal inference methods applied to questions about health equity. And so I'm really honored to give the Rob Mare lecture. So Rob Mare was a demographer who focused a lot on social inequality. And so I thought it'd be fitting for today's lecture to be about health equity and equity more generally. And so it's going to be kind of my musings on health equity. And so the World Health Organization defines health equity or equity as the absence of unfair, avoidable, or remediable differences among groups of people. And so I want to structure today's talk into kind of two sections. One, just kind of my personal experiences and my inspiration to study economics and health equity. And then also what economics can teach us about health equity, which I'll divide into kind of two brief sections. One is a case study that I've been kind of just thinking a lot about, and then ultimately my job market paper, which will kind of be the crux of this talk. And so I want to kind of a show of hands, who's heard of government cheese? So government cheese, for those who don't know, is refers to processed cheese that was distributed to welfare recipients and food banks in the 1980s. And it was a federal program mostly to kind of reduce the surplus of dairy, but also as a nutrition policy to kind of help low-income Americans afford or kind of eat food. And so in popular culture, kind of government cheese has been referenced in short stories by Junot Diaz, as well as some kind of music by Jay-Z. And it's kind of become a parable, sadly, of kind of government waste. And so how did government cheese come to be about? It started as when Jimmy Carter campaigned in 1976 by giving dairy farmers an equal break. And so at the time, kind of dairy prices were falling. And as a farmer himself, I think Jimmy Carter was very sympathetic towards this cause. And so he was trying to help kind of these struggling farms. And so they're kind of, as an economist, we know that there are two ways, or there are two levers to increase prices. One of them is to reduce supply. And so the government could have allowed farms to collude and then kind of artificially raise prices by restricting supply. And this is kind of the strategy that OPEC does to maintain high petroleum prices. But this is not what they did. What they actually did was to increase demand. And they did this by purchasing cheese. So in practice, the federal government paid $49 per 40 pounds of cheese, and they did this unlimitedly. So kind of any cheese manufacturer could sell their cheese to the government at this price. And it was a very expensive program. Over a couple of years, $2 billion was spent over 4 years. And it's kind of become symbolic of government spending or kind of good intentions gone awry. And so they stored all of these cheese still in cheese caves in Kansas. Like these caves are the size of kind of multiple football stadiums, and you can still visit them today. And so at the time, there was kind of 2 pounds of cheese per American. And so I think government cheese is not only an interesting story, but I'm also fascinated by it because of how it relates to my own personal story. And so my parents are Vietnamese refugees. They came to the United States in 1989. And they settled in Los Angeles, about 50 miles east of UCLA. And when they came to LA, they came here in Southern California, which has a very large Southeast Asian and Latino population. And they would frequent a food bank for several years. This is actually the food bank that they went to in Inland Empire. And they would actually receive government cheese from these food banks. And actually, these are some photos of I acquired some government cheese recently just to try it. So for those who haven't, it's kind of like a bittersweet cheese. Kind of my parents and me, like 85% of Southeast Asians are lactose intolerant. And so you'd have all these Vietnamese refugees come to this food bank and they'd be given cheese that they didn't know what to do with. And as you know, kind of like Asian food, like kind of the Panda Express does not have cheese, it doesn't have dairy. And so you can kind of think of this as a policy that kind of maybe leads to inequities because there are certain populations who aren't really receiving the resources that they're kind of intended to receive. But
the question
yes,
that's not really on topic, but still, people will be interested. Is lactose intolerance genetic, or is it a consequence of not having lactose as an infant?
I think it's mostly the former, so it's largely genetic. And you can see here really kind of exposure to kind of cows historically really leads to whether certain populations developed kind of the enzymes that they needed to process dairy, especially at an older age. And so there's a lot of variation, but I think about 15% of Americans are lactose intolerant, but in Asia, it goes to 80 to 85%. And so kind of what do we think about these inequities and what can economics teach us about inequities? So in practice, when my parents would go to these food banks, because it was largely Southeast Asian and Hispanics and Latinos, they would actually trade the cheese for other products from the food bank. And so we know that in the absence of bartering, individuals have to consume what's given to them or what they produce. And so my parents would kind of just toss away the cheese in this. But in reality, there was actually an underground market where kind of these Southeast Asians would trade the cheese for other goods and like foods that they can consume. And so this is kind of a cornerstone of economics where we know that there are gains from trade. And there's a lot of welfare theorems that tell us that when people can barter and exchange, especially when transaction costs are negligible, then welfare improves. But I think there's also a bigger question about kind of how can markets enhance equity as well. And so I think there's a big push, and I think there's a big kind of area of research where economists can think about theoretically how do markets and equities interact. And I think it's a really important kind of step forward. And so kind of for the remainder of the talk, I do want to talk about my job market paper, which relates to health equity in a separate way, and then kind of conclude with my musings on health equity more generally. About 1.3 billion people in the world, or about 1 in 6, have a significant disability. And people with disabilities have the same right to the highest attainable standard of health as any other human being. This right is inherent, and it's been affirmed through various human rights doctrines. But the world is also far from realizing this right for people with disabilities. This is because people with disabilities die prematurely, and they also experience poor health functioning. And so kind of disparities between people with and without disabilities that can't be explained by the underlying impairment are called health inequities. And so differences caused by avoidable factors such as ableism or discrimination, stigma, as well as the physical infrastructure are kind of inequities that lead to health disparities. And so one common hypothesis is that income or income inequality is an important determinant of these health inequities and these health disparities. But the kind of the causal evidence linking income and health is relatively scarce, especially for the population with disabilities. And so, for example, in the United States, adults with disabilities are twice as likely to die compared to adults without disabilities. And at the same time, these health disparities also mirror economic disparities where adults with disabilities have higher rates of poverty and housing precarity. And so in theory, we know that there are kind of many inputs into the health production function. Kind of public health researchers call the social determinants of health. And they include things like nutrition policy, like kind of government cheese, as well as kind of housing. But we also know through kind of a litany of studies that populations with disabilities have many barriers to access these inputs into the health production function. And so recognizing that these health disparities may be partly economic in nature, governments around the world have implemented cash transfer programs in order to increase access to these kind of inputs into the health production function. And so the question is, do these cash transfer programs improve health? And do they reduce health disparities between populations with and without disabilities? And so we know that the previous research on the causal effect of cash transfers is limited, especially for populations with disabilities. There's some studies on the SSDI program, which showed that it reduces mortality, but a similar disability insurance program in the Netherlands actually was found to increase mortality for men. And then kind of studies on the effect of cash transfers on health among the non-disabled populations is similarly far from unified. And kind of the range of causal estimates in the literature could be due to methodological differences across these studies, but there's also kind of variation in the size of these cash transfers, ranging from about 0.5% to 4,000% of median income. Let me skip that. So to kind of answer this question, I estimate the impact of cash transfers on health for veterans with disabilities. In the setting of my studies, the Department of Veteran Affairs Disability Compensation Program. And so the VA Disability Compensation Program provides financial support to veterans with service-connected disabilities. It's an extremely large program. Spending on VA disability compensation exceeds spending on SNAP and EITC. It's roughly 85% of government spending on the SSDI program for civilians with disabilities. And there are many advantages of studying veterans. The first is that veterans are an extremely vulnerable population with many health and economic disparities. Interestingly, they also have universal access to healthcare independent of whether they receive the cash transfer. So kind of unlike populations for whom we think that cash transfers might expand their access to medical care, for this population, they have very generous kind of low cost sharing health insurance. Second, we have access to very comprehensive data linking administrative health and death records for a panel of over 800,000 veterans between 2000 and 2021. And then finally, we're able to exploit two natural experiments in the administrative data in order to identify the causal effect of receiving a more generous cash transfer. So as a preview of our findings, the VA Disability Compensation Program provides between $130 to $3,000 per month. And in essence, a veteran first submits a claim to the VA, which is sent to a caseworker and a physician who generate evidence to substantiate or to reject the claim. That evidence goes to an adjudicator who makes the final decision. And my study exploits the random assignment of these claims to both caseworkers and physicians who vary in their tendencies to kind of award or reject claims. And so what do we find? I find that being assigned to a caseworker or physician in the 95th percentile of leniency is associated with an increase of about $300 per month more compared to being assigned to an agent in the 5th percentile of leniency. Second, kind of our two-stage least squares or our instrumental variable strategy implies that an additional $300 per month reduces 5-year mortality by about 0.8 percentage points, or about 10% of the mean mortality in the population. I estimate that these protective effects of cash transfers are the largest for kind of veterans with mental health conditions, but I estimate a precise null for those with musculoskeletal conditions. There's also a lot of heterogeneity, which I'm going to kind of omit from this presentation. And then finally, as I mentioned, there's kind of quasi-random assignment of claims to both caseworkers and physicians. And so we can kind of understand what happens if we have a natural experiment focusing only on the caseworker versus focusing only on the physician, and we kind of recover different causal estimates, which I'll kind of explain using a model.
Sorry, just to clarify, when you say these protective effects differ by, these are the reasons for their service-connected disability, not the, okay.
That's correct. So there are about 130 impairments that the VA considers disabilities. And then they submit those under different categories, mental health and musculoskeletal being the most common. Yeah.
Are you gonna show us a little bit about the quasi-random assignment?
Yes. So this is just a preview, but I'll go a lot more into the institutional details. For the sake of time, I'm gonna skip the contributions. So the VA Disability Compensation Program is one of the largest cash transfer programs in the country. In 2021, about $112 billion were awarded to 5.6 million veterans, or about 1 in 4 living veterans today. And so the payment that they receive is kind of a deterministic function of their disability rating, which ranges from 10 to 100%. So a veteran with a 10% rating receives $130 per month, essentially in perpetuity. A veteran with a 100% rating receives about $3,000 per month in perpetuity. And so kind of this line here represents the schedule linking your service-connected disability rating with your monthly payment. Some kind of facts about this program is that this is not taxed by the state or the federal government. It's not means tested. It's annually adjusted for inflation. Unlike the SSDI program, there are no restrictions on employment. So a veteran with a 100% disability rating can still work 100% or full time. And then the payment continues beyond retirement age. So you can think of this as an annuity.
What happens
Yes.
to veterans with non-service related disabilities?
Veterans with a non-service related disability won't receive any cash transfer. So you both have to prove the existence of a disability and link that disability to your service. You can still receive kind of income through the SSDI program if you can prove that that disability kind of prohibits you or kind of inhibits your ability to work.
Do you have any sense of the ratio of service-related and non-service-related disabilities among veterans?
In the veteran population, the majority of veterans who do have, the vast majority of veterans who do have a disability kind of receive VA disability compensation, or they can kind of link it to disability compensation. There is a selection issue because sometimes they might not claim that they have a disability if it's not verified by the VA.
But I was asking about the ratio of disability of service-related to non-service-related disabilities among veterans.
Yeah, the answer, so I would say that the data is difficult to get on that because I think a lot of veterans won't say they have a disability if they don't receive payments for the VA disability compensation. I think there might be some surveys that ask, but I'm just not familiar with this. Yeah. It's also important to note that kind of congenital disabilities aren't captured here because these are service connected. Most of them are kind of PTSD, amputations, and musculoskeletal ones. So kind of how are these disability ratings determined? It's a multi-step process where a veteran first submits a disability claim to one of 57 VA benefits office. That claim is first assigned to a caseworker, and the job of the caseworker is to help the veteran navigate the process. They interview the veteran, and they also collect outside evidence from the Department of Defense. During that kind of 4-month process, there's an appointment with a physician who works at the VA, and this appointment lasts between 30 minutes to 2 hours. And the job of the physician is to review the veteran's medical history and perform diagnostic tests. And then they both individually and independently provide evidence, which is sent into a kind of put into a packet, which is then forwarded to an adjudicator. And the adjudicator makes the final decision after reviewing the evidence. And so you can kind of.
What's the training of the adjudicator? Are they physicians or regular staff?
Yeah, good. So the adjudicator are former caseworkers. So caseworkers are first hired by the VA. They're called VSRs. And then after about 10 years, they can get promoted to the adjudicator level, or VSRs, or there are a lot of acronyms. But for the most part, they're not physicians. They're just kind of regular federal employees who have been trained to evaluate evidence. And so kind of the conceptual experiment that you can think of is that there are kind of two similar veterans who go to the same benefits office. Kind of one veteran is assigned to one caseworker and one physician. The other veteran is assigned to the other caseworker and the other physician. they might differ in their leniency or propensity to award payments. That affects their ultimate decision, which the adjudicator makes, and then they receive the payment. And so there are two features of this rating process that I think are very noteworthy for the study. The first is the veteran cannot choose their caseworker or their physician, and caseworkers and physicians have considerable discretion in how they allocate these funds. And so a very high profile example of this was a congressional testimony by kind of now Senator Tammy Duckworth of Illinois. And so Tammy Duckworth is an Iraq War veteran, and she had a testimony with kind of an IRS contractor who receives disability claims. And so it was said that Castillo injured his ankle by playing football at a military prep school. Kind of x-rays taken at the time did not reflect a fracture, and Castillo was given a disability rating of 30%. Whereas kind of Duckworth said, my right arm was essentially blown off and reattached. I spent a year in limb salvage with over a dozen surgeries, and I'm still in danger of possibly losing my arm. My disability rating is 20%. And so this is a very stark example of how the underlying impairment doesn't necessarily lead you to a higher kind of disability rating. And it's also this variation that I'm going to use in my study in order to kind of tease apart the effect of the underlying impairment as well as receiving a higher disability payment.
So is kind of disability rating related to the types of things they would be expected to be doing? For example, if the foot injury, even if it wasn't that extreme, sort of impaired the person from doing a particular job for the military, would that be rated as a higher disability versus sort of if your arm was not necessary to doing a task, like they would have considered that low? Is there something like that going on as part of these ratings? I'm just trying to understand that relation.
Yeah. So at the so kind of by law or kind of by regulation, there are 130 impairments that are qualified as disabilities, and each impairment has different levels. So for instance, diabetes comes to mind, where there's kind of 3 levels for diabetes: 10%, 30%, and 50%. And I think the only evidence that's used to kind of determine these ratings is the existence of the disability, and then also the severity of the disability, kind of independent. That's right. As long as it's linked to kind of a responsibility from the military. Yeah. Right. So kind of going into the data of the sample, we link kind of data from 3 sources. The first is the Veterans Benefit Administration, which contains disability claims submitted to the VA between 2000 and 2018. It includes the submission date, the disability rating, the impairment type, as well as importantly, the identifiers for both the claimant and the caseworker. We link it using Social Security numbers to the Veterans Health Administration, which contains health records for the universe of veterans who submit or don't submit claims from 2000 to 2023. Kind of this data set contains outpatient, inpatient, and homelessness services at all VA health facilities. We also have kind of diagnostic codes, and I create a measure of medical acuity based on these diagnostic codes. You kind of think of medical acuity as their kind of probability of mortality based on comorbidities and diagnostics. Yeah.
Why did you make your own instead of using the CAN score, NOSIS, any of the other?
I use the Elixhauser comorbidity index. I just call it medical acuity for like the general. Yeah. And then also here we can observe physician identifiers as well. Lastly, we link this to the National Death Index, which is the gold standard data set for mortality among the veteran population. And so this data set is sourced from VA records, the National Cemetery Administration, CMS, and the Social Security Administration master file. This is a very this is again known to be the gold standard because it has a high sensitivity rating. The sensitivity rating being 1 minus the probability of type 1 error minus the probability of type 2 error. And so compared to just using the SSA master file, it has a much higher sensitivity rating. And so we can kind of be pretty confident of kind of when these veterans actually die. And so I select a sample using the following criteria. I look at veterans who submit an initial disability claim between 2001 and 2018. That claim had to be evaluated by a caseworker with at least 200 other total claims, as well as a physician with 200 claims. And importantly, setting up this conceptual experiment, that claim had to be evaluated at a VA location, year, and impairment type with 2 caseworkers and 2 physicians. And the reason why this is important is because when a veteran comes to, let's say, VA Los Angeles, there's only a chance that they're going to be evaluated by a Los Angeles physician and not by a New York physician. And so you need at least kind of 2 caseworkers and 2 physicians at that time in that location in order for the experiment, kind of the conceptual experiment to hold. After applying these criteria, our sample includes kind of 800,000 veteran claimants, about 2,400 caseworkers, and 2,700 physicians. And so these are summary statistics for the veterans who are in my sample, meaning those who submit a disability claim. And then to kind of benchmark these summary statistics, I also use the health data to identify veterans for whom I'm very confident never submit a disability claim and don't receive VA disability compensation. And so you can see kind of along these demographic lines, they're pretty similar along age and kind of observable demographics. But as we expect, veterans who submit for a disability compensation claim utilize more healthcare in the year prior to submitting their claim, and they are also sicker. So they have higher rates of comorbidity, mental health conditions, and chronic conditions like diabetes. And like the general population, kind of the mortality rate for veterans who submit a disability claim are twice as high compared to the mortality rate of veterans who never submit a disability claim. And so kind of these health disparities within the veteran population mirror the same health disparities that we see in the general population. Similarly, kind of looking, these data don't come from the VA, but they come from the ACS. We see that for veterans who have a VA disability compensation, they also have lower earnings and lower labor force participation rates, which also mirror the economic disparities that we observe in the general population. Just for the sake of time, I'm going to kind of go quickly on this, but there are various sources of selection bias and why we can't just use ordinary least squares in order to kind of estimate the causal effect of receiving cash transfers on health and mortality. This is because veterans with severe impairments might receive larger payments on average, as well as kind of on the flip side, we know that recessions induce people to submit disability claims, but might lower short-run mortality in the economy. And so if we just look at the comparison of veterans with low disability ratings versus those with high disability ratings, we actually see evidence for the former, where veterans who have higher disability ratings have higher baseline comorbidity, and they also have higher mortality rates. And so if you interpret the OLS estimates as causal, you might naively think that receiving a higher disability rating or receiving more cash transfers would actually lead to higher mortality. And so we overcome this confounding problem using an instrumental variable strategy. And so this strategy kind of looks at the relationship between YI, the outcome. The primary outcome is going to be mortality measured 5 years after submitting your claim, but we also look at other kind of comorbidities and chronic conditions to understand mechanisms. Kind of SI is a vector of fixed effects, and so these fixed effects are kind of VA office times years times impairment. So within this cell, we believe that there is quasi-random assignment to caseworkers and physicians who adjudicate or who evaluate the claim. And kind of in this setting, we have beta, which represents the average causal response, which I've adjusted to represent $300 per month in 2018 dollars. So you can kind of interpret all of these results as what happens when you give a veteran, like the median veteran, about $300 per month in perpetuity. And so what are the instruments that we use? As I mentioned, I'm exploiting random assignment of claims to caseworkers and physicians, and these caseworkers and physicians might have underlying leniency or propensities to award payments. And so I follow the literature on the kind of judges design, where I take the leave out mean score to estimate their leniency. And so the intuition behind this is, suppose there's 2 physicians, there's no differences in leniency, and there's random assignment to those 2 physicians. If there is indeed no differences in leniency, they should on average award the same amount. But if one physician is on average more lenient, then they should be associated with higher disability ratings. And so because we do have kind of quasi-random assignment, those who are more lenient should have a higher instrumental variable score.
Sorry, I'm still not getting the evidence of quasi-random assignment. Are you coming to it?
Yeah, so I'm just claiming this at this point, but I'll provide some evidence, or we're kind of like rhetorical as well as empirical evidence in support of quasi-random assignment. But just believe it at this point when generating this data.
I'm with you.
Okay, awesome. And so just some estimation, I'm gonna estimate beta using two-stage least squares. I analyze things at the claim level, but I reweight it so that kind of an individual veteran has equal weight with another veteran. And then I cluster my standard errors at the caseworker and physician level. All right. So first, there are 4 identifying assumptions in order for us to kind of believe that two-stage least squares recovers a causal estimate. The first is relevance. So it kind of asks, do caseworkers and physicians vary in their awarding tendencies? And so what this does is it plots the histogram of the caseworker tendency instrument that I talked about before. And can you see that there's a lot of variation in that some caseworkers are very stringent and some caseworkers are very lenient. And there's a strong correlation between the caseworker that you're assigned as well as the ultimate kind of payment that you receive. So veterans who receive a very stringent caseworker receive lower payments than those who receive kind of who are assigned to more lenient caseworkers. And this is a very strong and statistically significant monotonic relationship. And then kind of going to your question about which is independence. So kind of are claims in fact quasi-randomly assigned to physicians conditional on a location, a year, and kind of impairment category? And so this figure plots the same relationship, but instead of looking at the relationship between the caseworker instrument, we're looking at the relationship between the caseworker instrument and the estimated transfer. And so this estimated transfer is the payment that they receive predicted on baseline characteristics and demographics. So we can observe demographics like age, race, sex, as well as a host of chronic conditions measured prior to submitting the claim. And so we use all of this data to predict the payment that you would ultimately receive. And then so this variable is kind of a weighted average of baseline characteristics and demographics that should be uncorrelated with the instrument. So in fact, we see that there is no correlation between this predicted variable using baseline characteristics and the instrument itself, which I think provides evidence of that. Kind of even absent of this empirical evidence, kind of VA rules kind of work in the way that a claim comes to a VA office. Let's say there are 2 or 3 caseworkers working at that time. Whoever has the most availability is assigned to that case. And so insofar as claimants can't kind of pick and choose when they don't know the availability of caseworkers, they just submit it at a given time and then it's assigned to whoever who has the most availability. Right. So kind of everything I've shown before was for the caseworker instrument, but similarly, when we run this exercise on the physician instrument, we see that there's a lot of variation in physician leniency. There's a strong correlation between physician leniency and the actual payment that veterans ultimately receive, but no correlation between physician leniency and kind of the baseline characteristics that are used to predict payments. All right. So kind of the third assumption is exclusion. And so kind of do these caseworkers and physicians award like instruments affect health and mortality beyond their impact on the transfer income? And so the answer here is maybe. And so kind of how you interpret these results kind of is based on kind of whether you believe these assumptions. And so I think for the caseworkers, it's pretty straightforward. The job of the caseworker is only to interact with the veteran in order to gather evidence for the ratings process. They don't provide care, they're not physicians. They only kind of see them during this process, never before and never after. For the physicians, like maybe it's different. I want to highlight these physicians are employees of the VA. Legally, they're not allowed to be their primary care physician. And so they only see them for the 30-minute to 2-hour visit. You might think that during that visit, maybe these physicians who are also trained to treat kind of other veterans might be treating them during this timeline. Looking at their clinical notes, I don't see any evidence that they are providing care, especially in such a short period. But this could be a threat if you think that more lenient physicians are more likely to provide care. And this leniency kind of is also associated with their kind of health outcomes independent of this. In the paper, I kind of provide different kind of exercises testing this hypothesis, which I'll omit for the sake of time. The last thing I want to highlight is that these disability scores are also associated with non-cash benefits, but they are kind of stable, are very small in comparison. So kind of veterans who receive a non-zero disability rating are also eligible for vocational rehabilitation and grants for their housing and automobile. But compared to 100% of veterans who have a non-zero rating receiving cash, only 2.5% receive vocational rehabilitation and less than 1% receive these grants.
But for physicians, is it possible they could direct them to additional services? So, for example, PTSD and, recommended specialists or recommended kind of other service. Or is that something you would see in the clinical notes?
It could happen that they don't write it in the clinical notes. So the clinical notes are just free text that the physicians write, are uploaded into the data set. I really, it's been a long process, and so there's could be a role of NLP to do this, but kind of just reviewing 100 random notes, and none of the notes was I able to find that they did anything outside of their scope of responsibility in evaluating the claim. But it could happen, but just not be recorded in these notes. I think talking with veterans and physicians, these appointments are very quick, and they're very rapid. And physicians are overworked. And so they often tell me that oh, I just do what's required. There's a form that they have to fill out, and then they just take on the next patient. But that's hard for me to verify without the actual empirical data.
I've seen maybe there's evidence of what going to the doctor does for mortality, but even a 30-minute meeting, the doctor can improve your mortality by 10%. They're the best doctors that ever lived. It seems reasonable to make that assumption.
Yeah, that's right. And so it's about a 6-month process. So you apply for your disability claim, you are sent to a caseworker, and then during that 6-month process, you're assigned to a physician. And so it could be that receiving cash transfers affect your healthcare utilization, but in that short period before receiving the transfer and seeing the physician, I don't observe any change in healthcare utilization. And this is in the short run, so it's hard to claim, but you're right, and it's hard to see any differences in healthcare utilization, let alone mortality, if we don't see any changes in treatment.
I was going to address the question of physician movement between the health side and the benefit side. I hate to answer what should be a data-driven question with anecdote, but I've been at the VA since I was a medical student in various ways. I met the first person from the Veterans Benefits Administration who was one of these reviewing physicians 2 years ago, after already having spent about a decade in various ways interacting with the VA. So I thought a total wall.
You mentioned that the assignment to caseworkers is random. Is the assignment to physicians also random or somewhat based on their specialty and the particular impairment?
Yes, so they're both random based on institutional rules, and I think the empirical evidence supports that. The way it works is you first submit a claim, and then that is sent to the caseworker with the first availability. During that sequential process, let's say 2 months later, the caseworker actually makes an appointment with the first available physician. And the physician, of course, has to be within the specialty, so an oncologist to see cancer care and audiologist for tinnitus. But that's also assigned based on the physician with the most availability. All right, I'm gonna skip this
Do you
because
have any evidence or that different specialties are more or less lenient?
Yes, so it's hard. So I'm going to talk about the first stage results, but I will say the data get granular, and especially for specialties like oncologists, there's usually only one physician working at that time. And so it's really difficult to compare them. Most of the variation and most of the data come from mental health and musculoskeletal. And for both of those, they both seem to have similar first stages, meaning that being assigned to a lenient one physician is associated with similarly changes in your cash transfers. All right, just in the last 10 minutes, I wanted to talk about the results and then end with my musings on health equity. And so the OLS that I mentioned previously.
Do we have a half hour?
Oh, is it? Okay, is it 1 or 1:30?
1:20.
Oh, 1:20. Okay, I guess I'll go slightly slower then. And so I previously mentioned that the OLS estimates are biased because it could be that the underlying impairment that qualifies you for a more generous cash transfer also affects your mortality. And indeed, we see that for veterans who have higher disability ratings, actually have higher mortality rates 1 to 10 years after the disability process. The two-stage least squares actually shows the reverse. And so it seems that those who receive more generous cash transfers actually have lower mortality rates. So we see that receiving an additional $300 per month reduces, say, 5-year mortality by about 0.6% or about 10% of the mean. And this is a pretty large kind of estimate, and it's also consistent with previous literature looking at the effects of cash transfers on mortality in other populations, even though this literature is also very mixed. And then interestingly, we see that the two-stage least squares peaks in year 6 and then kind of dissipates by year 9. This is consistent with many health capital models where it takes time for health capital to accumulate, but also it always reverts in that kind of you can be given $1 million, but kind of 30 years, 40 years in the future, everyone dies. So we should expect kind of a reversion to zero at some point. And so we see that cash transfers improves life expectancy and reduces mortality. And so the question is why? And so using the rich data from the VA, we're able to analyze changes in healthcare utilization in the 5 years following kind of submitting your disability claim. And I divide this utilization into kind of 3 categories. The first is preventative care. The second is kind of more emergent or kind of inpatient or emergency room care. And the last is that because the VA is a very comprehensive healthcare service, they also provide homelessness services or kind of housing services to veterans who have housing precarity. And so what do we find? We see that cash transfers boost utilization of primary care, which primary care and mental health care, especially mental health care, where there's an increase of kind of 2.5 visits over 5 years on a baseline of kind of 12 visits in this population. Interestingly, we don't see any changes in emergency room or inpatient utilization. It's a very precise null. And kind of a very interesting finding is that even though this program is not specifically a program to reduce homelessness, we do see that there is a reduction in the utilization of homelessness services within the VA. And so it could be that veterans, are not using these services because they have access to kind of larger cash transfers. And so it really points to income and poverty as a really important determinant of kind of rising homelessness and homelessness in the veteran population generally.
So 2 questions. So what in the VA, do I pay anything for these mental services if I would do, I can pay for them?
So the VA is unique in that cost sharing is essentially 0, especially for primary care and mental health services. And in fact, I think it's actually 0.
Okay, so the cash transfers make me use more of those, but it's not because I have more income to spend.
Yes.
Maybe I have more time, but I don't more, there's no cost. And another thing with homeless services, I'm getting these are pretty expensive. To what extent does this offset the cost of the cash transfers? Like, does it just make sense for the VA to do this because we can just spend less on homelessness services?
Yeah, good question. I did run a back of the envelope kind of calculation. Only about 1 to 2% of veterans use homelessness services, but those who do use it a lot. At the end of the day, it's like most of the money goes to veterans who don't utilize homelessness services. And so from a cost benefit analysis, like cost effectiveness perspective, it's a if your goal is to reduce homelessness, just providing the money for this program is much more effective at reducing homelessness or utilization of homelessness services. And kind of on your first point, I do want to highlight that it's really important for the interpretation that because veterans have essentially 0 copay and 0 co-insurance for these preventative care services, the interpretation could be kind of one of 2 things. One is that veterans are maybe reducing their labor supply, and there's kind of work by David Otter showing that when veterans receive disability compensation, they reduce their labor supply, and so maybe they free up time to go to the doctor. It could also be that their affinity towards the VA increases. So there's a lot of studies on universal basic income. When you give people money, kind of unsurprisingly, their kind of affinity towards the government increases. And so maybe they're more fond of the VA, so they're more likely to use these services.
I actually just wanted to ask along those same lines, and I apologize if you already explained this. How do you account for their prior utilization? Because this is something that very often happens when a veteran is first establishing care or reestablishing primary care at the VA. That either they'll be doing this simultaneously on their own, or the primary care doctor will tell them to go ahead and do that as well.
Yeah. So I would say 50% of the claims in my data set, veterans have no prior utilization with the VA. And so it's kind of coincides with, and so it's just coded as a kind of 0 utilization in the prior period. 50% do have care because they received care and then they apply for disability compensation at a future date. But all of these results look at utilization in the 5 years after applying for the disability compensation.
I guess the question then in my mind is, how does that change relative to prior utilization? Is this actually reducing emergency room visits? Is it increasing primary care? And you can't do that without a baseline.
Mm.
These results hold when you only look at people who have prior utilization.
Oh, so these results look at everyone. So this includes all 800. So half of them do have prior utilization. And so you can think of this mean as their mean utilization in the 5 years after. And so it could
Yeah,
be.
I'm talking about the delta between before and after.
Okay.
And that's where I think you should really see if these results, if there's a change pre and post.
Okay, got it.
The half of people who have prior data.
No, that's interesting. Yeah.
Or you should put that in your instrument someday if you didn't already and I just missed that.
No. I think these look at differences between those who receive high versus low payments, but I think there's an interesting point about the kind of over time, the changes, which is not kind of captured in these results.
The other thing you'll want to keep in mind with that is that like you can, as a physician, you can tell when disaster is coming and they may need to increase their their service connection, not just for money, but for long-term care benefits.
Yeah.
And so like, you may want to also specifically look at people, for example, who like newly get diagnosed with dementia, because that's a very common, like, okay, your memory is still kind of there, go to CMP, the benefits administration folks, and like get evaluated, where you can still talk about your service so that maybe you can qualify for long-term care.
Yeah, good question. And then actually, I think I'm gonna have a model at the end where I kind of talk about what physicians are actually kind of maximizing when they allocate these, which hopefully will kind of address or kind of touch on this point. Okay, so more about mechanisms. This looks at kind of the effect of receiving $300 per month on whether you receive a diagnosis for different conditions. And so about 51% of my sample has a diagnosis for a cardiovascular condition, but when you receive cash transfers, it actually lowers your probability of receiving or having a diagnosis in the 5 years kind of after applying for this. And so we see that for metabolic conditions like cardiovascular disease and diabetes, there's a reduction in the prevalence of these conditions. Interestingly, we see an increase in the prevalence of mental health diagnoses. And so there are kind of two interpretations for this. One, it could be that maybe giving cash transfers does harm mental health. But another intuition or interpretation is that we know that cash transfers increases your utilization of mental health services. We also know that there's an underdiagnosis of mental health conditions. So it could be that there is underlying mental health conditions, and when they go to the kind of psychiatrist or psychologist, they're being diagnosed for an underlying condition. Ultimately, it's difficult to tease it out, but I do think that kind of the metabolic conditions do suggest that their health is improving in kind of the conditions that are most associated with mortality in this population.
So the hypertension, that can be lowered just by taking medication, right?
That's right.
So this is a really easy, they diagnose it, they get you on medication. It's, you see like a very direct effect on the morbidity, but also probably on mortality. Right?
Yeah, that's right. But yeah, something I'm still working on is kind of prescriptions. And so I don't have any results for you now, but I think it would be consistent with that story if we see an increase in prescriptions or adherence for existing prescriptions. And also I want to highlight that prescriptions are also, especially for generic drugs at the VA, costless.
I would also say things like diabetes and diabetes related complications are it seems to me like harder to address quickly and in the short term, and they may have effects that are, are going to show up kind of longer term, right? But things like, CBD and sort of its connection to hypertension and fast connections.
Yeah.
So it's nice that you kind of are seeing some of those. I guess it lends some faith.
Definitely, yeah.
Yeah.
All right. This looks at heterogeneity by the type of impairment. So I previously mentioned that there are 130 different types of impairments that the VA considers disabilities. And so we can then categorize them into these categories and then look at the treatment effect of receiving $300 per month on 5-year mortality when we only use kind of claims for musculoskeletal condition, kind of auditory. Interestingly, we see a very precise null effect, meaning that veterans who submit a claim for a musculoskeletal impairment, when they receive more generous transfers, don't have a reduction in mortality. In contrast, for those with auditory and mental health conditions, we see that those who receive more generous transfers have a large reduction in mortality. And so kind of, I think it was pretty puzzling, kind of this auditory result. I've been talking with physicians, and maybe you can kind of confirm that. I think 95% of people with tinnitus, which is ringing in your ears, also have depression or anxiety. And so there's a very strong correlation between mental health conditions and auditory. And so I kind of think of these as more closely related than those with kind of musculoskeletal conditions. We see kind of like no significant effects, maybe a positive increase in mortality for neurological conditions, but I personally don't put too much weight in that. And kind of these other conditions, which are smaller cells, we also don't estimate kind of large treatment effects. All right, and then the remaining time I wanted to talk about heterogeneity and what we can learn about heterogeneity in this model. And so I've shown this figure before, which looks at the effect of receiving $300 per month on mortality measured 0 to 10 years after. And these these squares estimates combine instruments from the physician instrument and the caseworker instrument. But what happens when we decompose them? Because we theoretically have two natural experiments, and a quasi-random assignment to the caseworker and quasi-random assignment to the physician. And so if you only use the variation from the physician, you would estimate treatment effects that are more than, or I guess, less than half of the size compared to if you use the physician, the caseworker instrument. And so kind of these are statistically significant. And so kind of one question is why, right? Like it could be that, I guess I'll give you the answer why. So the answer I'm going to argue is about compliers. And so when we estimate two-stage least squares in the presence of heterogeneous treatment effects, we are not estimating the average treatment effect necessarily. We're estimating the local average treatment effect. And with kind of a continuous treatment, we're actually estimating the local average causal response. And so who are compliers and what is two-stage least squares doing? This is kind of what two-stage least squares is doing, which is a weighted average of different walled estimators. And so what the walled estimator is kind of the effect of receiving, the effect on mortality of being assigned to a more lenient agent divided by kind of the effect on your cash transfers of being assigned to a more lenient agent. And so compliers are individuals with non-zero weight, meaning if you're someone who is not induced into receiving higher cash transfers by when you're assigned to a lenient agent, then you get zero weight. And so it could be that those who are induced into higher payments by caseworkers are not necessarily the same individuals who are induced into higher payments because of due to caseworkers. And so kind of the intuition behind this is that suppose there's a lenient and a stringent caseworker, a never taker is someone who will not receive cash transfers or a generous cash transfer, regardless who they're assigned to. An always taker is someone who will receive generous cash transfers, regardless of who they're assigned to. And so you can think of as never taker as a veteran who will say, does not have a disability, and it's very easy to ascertain that they don't have a disability. So they can be assigned to the most lenient caseworker, they're still not going to receive the treatment. An always taker is someone who says has double amputation, it's very easy, even if you're assigned to the most stringent caseworker, you'll still receive a generous cash transfer. So compliers are those who are kind of more difficult to evaluate. But the ordering of never takers, compliers, and always takers could be different for physicians because physicians look at different kind of components of the claim. And so who's difficult to triage by a caseworker might be difficult than who's difficult to triage, might be different than the who's difficult to triage from the physician perspective. All right. And so what this figure does, it just uses some insights from Abity in order to characterize these compliers and look at kind of medical acuity and different kind of conditions or demographics, depending on whether you're a caseworker complier versus if you're a physician complier. And indeed, we see that caseworker compliers are less sick on average compared to physician compliers. They're also younger, but they don't really differ that much along kind of where they live and then kind of their zip code deprivation. All right. And then I also want to conclude by talking about the marginal treatment effects without going kind of into too much technical detail. The marginal treatment effects looks at the relationship between the propensity to receive the treatment and the treatment itself. And so the idea behind this is if you have a very low resistance to treatment, then you are an always taker. So you could be assigned to the most stringent agent, you'll still receive a lot of kind of more generous cash transfers. Whereas if you have a very high resistance to treatment, then you are a never taker. Meaning if you're assigned to the most lenient agent, you still have a low propensity of receiving the treatment. And so what this does is for individuals with different levels of resistance to treatment, it plots your treatment effect. Meaning that here, individuals who are never takers or more likely to be never takers have a larger kind of effect than those over here. And so kind of looking at this, we see that kind of those who are also the most or the least resistant to treatment are also sicker on average versus those who aren't. And so I want to combine this evidence by kind of going through an exercise where we see that those who are sicker on average actually have less of a benefit from cash transfers than those who are more marginal. And so kind of talking about disparities, I previously showed that those without disabilities have a 4.3% mortality rate, kind of 5-year mortality rate. Whereas veterans who submit for a disability claim have an 8% mortality rate. And then from the two-stage least squares, I showed that receiving $300 per month lowers mortality by about 1 percentage point. So kind of cash transfers on average narrow health disparities between populations with and without disabilities. But we also know that the population with disabilities is very heterogeneous. And the effect of cash transfers also varies depending on your underlying impairment. And I find that veterans who are the sickest actually have the smallest to gain compared to the veteran who's marginal, who has a lot to gain. So among the population of veterans with disabilities, we see that actually disparities can exacerbate when we give them cash transfers.
This also applies on, I think, outcomes mortality, and it's maybe not surprising that if I'm extremely sick, cash is not going to affect my mortality very much, but it could still make my quality of life, make life care a lot better. So I mean, I think it's kind of completely keep in mind that this is mortality specifically, because I know the inequality. I don't know if the implication is we should give less cash transfers to very sick people.
Yeah, no, I fully agree. I think it's important to know that this only looks at mortality. And for someone, let's say with double amputation, who's extremely sick, again, you could give them $1 million, kind of their life expectancies might maybe set in stone. And so we don't see any movement here. From like a policy perspective, it could be that it is kind of utility increasing in other aspects. And so this, I think, more so talks about kind of a deeper social science question of the effect of cash on health disparities. And if our goal is to minimize kind of mortality disparities, how does this affect it? But I would totally agree that kind of cash transfers serve many different purposes.
Yeah, I'm just saying stuff that's kind of an equity efficiency trade-off, but it's really focused on mortality as the outcome. And when we actually think about efficiency, we would want to think about all of wealth and
Yeah, definitely. And I also want to highlight that this program is not a health program. And so this is a compensatory program from the government. The goal is not to improve health. But the fact that we see kind of an increase in overall health does kind of speak to the link between income and mortality and health. But I think there are different kind of objectives of this program. And when we think about equity, it's important to think about kind of those different objectives. And so kind of my final conclusions on kind of health equity. So I want to repeat the definition of equity as the absence of unfair, avoidable, or remediable differences among groups of people. So it's important to note that health disparities doesn't necessarily imply the existence of health inequities. So in the population with disabilities, there are underlying impairments. And even if there was no health inequities in society, there would still be health disparities because the underlying impairment affects your health. So it's really difficult, I think, as researchers to quantitatively know whether a health inequity exists. But I do think that there is a role for economics and empirical methods, as well as kind of qualitative methods and interdisciplinary methods to understand whether and to what degree these disparities, which are easy to observe, can be remedied by policy and are thus kind of health inequities. I want to conclude, and then this is why it's called amusing and not kind of, there might be some pushback, but I think economic theory can teach us a lot about equity. So kind of as the many economists know, we have a lot of theorems in economics that tell us that under certain conditions, kind of markets yield Pareto efficient outcomes. I do think, and I'm not a theorist, but if someone here is a theorist, that I'd be really interested in knowing whether there's a theorem or there's something where markets under certain conditions can also yield equitable outcomes. And kind of, can we create these conditions like in kind of the government cheese example, where we want to kind of have individuals who are maximizing utility lead to equitable outcomes, and when they're not equitable, kind of what policies we can implement to make them more equitable. All right, thank you.
We have some time for questions. So Johnny, I think you've got.
Oh, yes.
Just going back to the, quasi, random assignment.
Yes, yes.
So you mentioned, availability
Mhm.
aspect. So is there any look for information on that? Do, veterans know about the screenings or leniency of the case workers? For example, if you're assigned to the DMV at Santa Monica, I would cancel the appointment right away because it's one of the highest ones to pass the driving test. So, could you speak about that?
Yeah, that's a good question. You are assigned to a VA office based on your address. And so it's kind of divided into about like 14 VA offices in the country. And so you can't choose your office unless you moved from your address. And so I would say that veterans do know that certain offices move more quickly or they might be more lenient. This is kind of talking with veterans, but they don't know within a given office how to choose the timing in which to choose the caseworker who's most lenient. And I would also argue that they probably don't know who's the lenient caseworker. So in this setting, I'd say like, yes, there is information and that might affect at the margin, maybe where you locate to have a more lenient VA, but kind of conditional on the location that you're at. There is, I think, plausible random assignment to the caseworker.
I was wondering, I think for your main models, you said you were comparing those who receive less than 50% disability rating with those greater. Is that the more generous, less generous divide?
Oh, sorry, you talking about this table?
Well, just for your main models, did you use this binarization?
No. So, okay, so for this one, it's mostly just a descriptive exercise to talk about why the OLS would be biased. All of the two-stage Z-squares and kind of beta coefficients are scaled to represent an additional $300 per month, which is approximately 10% at the median.
Are you able to tell how, I'm just wondering if there's sort of a threshold effect where if you put that cutoff somewhere else, you might see different results. We're getting, like over 1,000 or, whatever it is, that there might be different.
Yeah, no, I think there's potential for nonlinearity in one kind of specification, which is not in here. I was looking at the different treatment levels. So as I mentioned, you can go from 0 to 100% in increments of 10%. And so you can think of it as 11 separate treatments. But at the end of the short story is that like I wasn't powered to detect treatment effects along kind of those margins. But I think that there's something potentially I could do to look at potential nonlinearities. But that's just not the result I have right now.
If you go back to the local average treatment effects for the caseworkers versus the
Yes.
physicians. Something I thought you were gonna mention, and I don't know if it's just been mentioned, is the implication here that caseworkers are much more responsive to the marginal benefits of money for you? Like it seems like basically the caseworkers are lenient or identifying people are very high for money for them. I mean, the doctors are not doing that basically.
That's one potential interpretation. So we know that these treatment effects are all along compliers. But I think to make that statement, we'd have to look at the treatment effect for always takers, because it could be that if caseworkers are better at allocating money based on gains, we should see kind of larger treatment effects.
No, I mean,
Yeah.
marginal.
Oh,
And
yeah.
of course, we can't. see
Yeah.
here, But it seems to be saying that a caseworker who is relatively more lenient
Mhm.
gives more money to people who specifically on the margin who have high returns.
Yeah.
As opposed to what the physicians.
That's right. And I think the MTE curves also kind of like speak to that as well, where we see like a downward sloping curve. And so it kind of talks about like, for those who, actually, I didn't go too much into detail, but I think, yes, I think there is more I can do to kind of push on kind of why these caseworkers have larger treatment effects and if they're targeting kind of cash transfers based on gains.
Since the caseworker was dealing with 3 months or whatever, like
Mhm.
17,000.
Yeah.
Status, whatever, but the doctor will see you for 20 minutes and says, is he sick or not? Like,
Yeah.
So it doesn't seem crazy, but it does seem kind of interesting that the caseworkers seem to be able to respond to information in like a smart way. Well, the lenient guys are relatively more responsive to information.
Yeah, definitely. And I think it like broadly, I think there's this growing understanding that kind of healthcare actually explains very little of health. And so kind of knowing where you live, kind of who your social network is, could be a better complement for cash transfers than kind of your underlying health. So it could be very true that like caseworkers have more information, they see them for longer, and so they're better able to target those cash transfers at the marginal applicant in order to maximize treatment effects.
Have you considered the possibility that that the difference in leniency is associated with characteristics, demographic or social characteristics of the physicians and the caseworkers, sex, race, age, etc.?
Yeah. That is something in the process. So in my data set, I only observe the name of the physician. And so you could kind of maybe tease out gender and maybe race from it. In a future one, I have the NPI codes or the National Physician Identifiers. And so I'm working to acquire the AMA master file to link in demographics, to look at who are lenient physicians and kind of how do they differ along observable demographics. But I don't have an answer yet.
Okay.
Yeah.
I'm also thinking about how caseworkers have to make two decisions.
Mhm.
One is about the degree of disability and the other is about the degree to which it's due to military service.
Yeah.
And in this analysis, you don't distinguish. I mean, obviously they're conflated, but is there a way you could learn more? Say, one caseworker might want to say, it's solely the military's fault. And so even though you have a small disability, I'm going to give you more money. I'm
Yeah.
going to recommend more money because I think it will really help you and the government is at fault.
Yeah, that's true. I think there are two dimensions that both caseworkers and physicians are looking at: the existence of impairments and then whether that impairment was linked to service. And using this design, I kind of collapse into like a one-dimensional index of leniency, but they could differ along those leniencies. Without like any more data, it's difficult to measure them, but I will kind of talk about the institutional details about kind of how it might be affected. And so this is called a DBQ, or a Disability Benefits Questionnaire. And so this is the form that physicians are filling out during the appointment. And so this one is for sleep apnea or obstructive sleep apnea. There's a lot of yes or no checkboxes. And at the end, there's kind of a free text where the kind of physician is able to write their opinion. So it's kind of, it is my opinion that obstructive sleep apnea is more likely than not incurred in or caused by the claimed in-service injury, event, or illness. And so I think at the end of the day, like the adjudicator is looking at the kind of just the packet of evidence, the yes or no checkboxes, and then making the decision that there's both an impairment and that it's linked to service. But it's hard for me as like a researcher to tease out the different ways in which they might be linked.
But are both the caseworkers and the physicians evaluating both?
Yes. Both are necessary conditions to receive it. Yeah.
Two questions. The first is about the main results.
Mhm.
You see an increase in like the primary care utilization.
Yes.
So even though it doesn't cost them to go to the doctor, like you just mentioned, there's only 14 facilities, so I might live very far from it, and so it will cost me to get there. So I wonder if having more cash allows me to go to the doctor more often through this sort of like transportation channel.
Potentially. So actually there are about 1,000 VA healthcare facilities. So there are 14 benefits regions. But yeah, it could be that a lot of veterans, especially in rural parts of the country, have kind of access to transportation issues. And kind of cash, one mechanism could be that cash is kind of increasing their access. I don't have data on transportation, so I can't actually like empirically assess whether that's true though.
The second one was about the adjudicators and how much, like what is their decision? Are they looking at the number of checkboxes and is there like an algorithm they use, or like do they have a lot of discretion as well? In which case maybe you actually have like pretty.
Yes, yeah, I think I don't have the identifier of the adjudicator, and so this would be a 3 judges design thing otherwise. And I do think there's a lot of discretion.
It's not random.
Yeah. My understanding that it is randomly assigned. So once the claim is done, it's sent to the adjudicator with the most availability as well. And kind of reading through the evidence, I actually think that there might be even more discretion for the adjudicator than there could be for the evidence, kind of people who are generating the evidence, because they have like the ultimate say. They're kind of just reviewing the evidence and then they kind of make the decision. But yeah.
Yeah, like thinking in like the typical judge I would in mind, right? Your caseworker in position could be just like the lawyers from opposing parties providing evidence. And like really the judge is like.
Definitely, yeah.
quick clarifying question on, is binary, this symptom or this thing was caused by the military service, or is it like, how much of it was caused?
So the legal standard is preponderance of evidence, which is at least I think over 50% that it is caused by it. And so it's not here, but there's a part of there's a checkbox where it's like, do you believe that, you know, the preponderance of evidence, or the definition of preponderance of evidence, leads you to think that they do have this claim. So they might not have the impairment, but kind of the preponderance of evidence suggests that they do, according to physicians or not.
And go see another.
Yes, so you could appeal, and the appeal is just restarting the whole process again. About 15% of people do appeal. 15, yeah. And in my analysis, I focus on just the first claim, and if there are changes, then I kind of use your disability, like your ultimate disability rating. And so you can think of this as an ITT or an intent to treat, but there is a lot of stickiness with the first rating that you receive is very, very correlated with the ultimate rating that you receive. Thank you all.